So good afternoon, everyone. I'm Nilanka Pereira. I'm a consultant physician from Department of Medicine at University of Sri Jawatanapura. And on behalf of Ceylon College of Physicians, let me cordially invite and welcome all of you to the Zoom session, where we want to address a very important topic today, that is mainly managing leptospirosis and other common infections that we're going to encounter in the aftermath of floods. So we plan to give a practical guide for first contact doctors. And let me first start by expressing that our President, Professor Prasad Khatlanda, has sent his wishes and then actually as the president of Ceylon College of Physicians, he has sent his regards and then all the wishes to continue this session today. And with that, I would like to move on to our first talk, which is going to be by Dr. Palitha Karunapema, the Chief Epidemiologist of the Epidemiology Unit, Ministry of Health and Mass Media. And so I would like to hand over the session to you, Dr. Karunapema. You can share your slides and then start your talk.
Thank you very much, all the college president, colleagues, and all the doctors. First of all, I would like to sincerely thank all the colleges inviting for this important session. We all know that. Can you see my slides?
Yes, we can see yes.
Yeah. This is an unprecedented situation we have seen after floods and landslide. So basically, this will create a lot of issues among the society. Now, we all know that 10% of the population affected, 1 in every 12 building affected, large amount of land flooded and affected. So it's a kind of an unprecedented situation. In this type of So in this situation, infections are common. I think it's a very, very timely seminar for the right. So as a first now, patients are coming to maybe OPD, maybe wards. As a GP, you will encounter in different contexts. So I suppose the first responsibility is we must be very empathetic to patients in this situation, and probably we need to identify their perspectives, and we need to take a very, very patient-centered approach in this situation. Apart from usual our history taking and all the examination, probably in this situation we need to identify potential risks. It may be the displacement, loss of family members, flood, landslide, you can name different type of risk. So please aware about and have a high degree of suspicion about all the different parameters. Next. Then today I think our focus is on mainly key areas: leptospirosis, acute diarrheal disease, respiratory, dengue, and other vector-borne diseases, and hepatitis. And so probably clinical perspective will be given by respective clinical colleagues. I'll mainly focus on broader picture. Now, what we need to have is a less impact on the society, and probably we need to reduce the morbidity and mortality. That's our aim. Now, there are a lot of activities in the preventive sector going on right now, along with the curative sector. Then when the patients come, this is where you come to play. Basically, to the OPDs, GPs, then if required, admitted to the wards, then appropriate treatment should be there. So I will focus my presentation on these different aspects. Mainly, our clinical colleague will talk about treatment component. When it comes to the preventive action, immediately after the floods and landslide, people are moved to the safe places. So our emergency PHI ensure that these places are safe to stay, ensure the hygienic condition, clean water supply, and safe environment. Those are very important. Then people are now going to back their homes. They're cleaning homes, cleaning wells. So we need to ensure clean water supply. Right now we have a massive effort to chlorinate wells. Then even immediately after the floods, we have initiated the provision of doxycycline prophylactic, considering the very high risk of leptospirosis. And again, PHIs ensure the food safety through regular inspection of these outlets, plus supply of foods to the Suraksha centers. Then again, we all know that dengue control program is working right throughout the period. I mean, minimize the spread of dengue, preventive actions were taking place. Then other very important point is we have enhanced our disease surveillance system. Then When it comes to early detection, we need to have a very high degree of suspicion of clinical diseases, then initiate treatment and refer. And other very important I want to highlight is the disease notification, because it's a primary responsibility of the treating doctor. Only then we can identify the broader picture of disease distribution in different districts, different provinces, and different level of emergence. Now, when it comes to the treatment also, other areas, it's a very golden opportunity to educate patient about various aspects. It may be patient plus patient family members. Avoiding of contaminated water, safe food practices, promote use of protective gears, hand washing, all the respiratory etiquette. There are a lot of things which very easily treating patient can provide information to the family members and the patient. So don't miss that golden opportunity, because we are having about 55 million patient visit to government hospitals. So use this opportunity to educate patients. This will definitely have impact on their behavior.
I will talk about the disease notification at hospital level, specifically focusing on hospital. In OPD, PCU, in wards, basically the treating physician should notify any communicable diseases, and a list is with you, and also it can be available in our website. So treating, that's a very important apart from the treating. So H544 is a notification form. So we must, every doctor is responsible for notification. So then as consultant, probably we can monitor what they are doing and ensure that all the notifiable disease in the ward level and in the OPD is being duly notified. Then the ICNO play a role in having maintained the institutional notification register and collect all the 4544 and notify the MOHs. Now we recently introduced the web-based platform Epinet, so they can directly, almost like on real-time basis, they can update the situation of the hospital, where they can also see the data of their hospital. So this is H544, and hospital level you have a communicable disease notification register, and MOH office you have a communicable disease notification register. Then this is the, I want to show you, last week we initiated this web-based platform. So every day the diseases are notifying. Now you can see that top line is the leptospirosis. Around 60 cases are daily reporting. That is not all the hospitals are right now reporting, because it's a early pace of implementation. Around 60 hospitals locked into the system right now. So probably we'll see more and more patients leptospirosis. So we should have a very high degree of suspicion, and we must be very proactive in combating especially leptospirosis. So this is the general pattern over the last few years. So last year there were 13,000 cases. Right now we have about 9,000, almost 10,000 cases, notified cases. So this is the general trend over the last few years. So we can expect a higher number of patients this year and early next year. So this is the trend pattern by month. So last year we had a massive outbreak, and fortunately so far we haven't seen that, but it is most likely that we might see this increase in trend over the next 2-3 months. And anyway, in November, December, and January, respiratory infection are going up most of the time, and with the influenza and other things, dengue probably will increase, and leptospirosis. So we must have very high degree of suspicion about all these important diseases. So we need to, I think clinicians are well aware about the importance of managing these diseases properly. Especially leptospirosis, we have about 1.7 case fatality rate last year. So probably this year, probably 2.3 last year. So I think with all the colleges, we should be able to reduce this further. So I don't want to go into this identification of high risk groups or leptospirosis, but all know that first responder, landslide affected communities, resident temporary shelters, Triforce, all volunteers, waste and all are high risk for leptospirosis. I think with that note, I conclude my presentation. So again, I want to thank all the colleges. So as a Ministry of Health Epidemiology Unit, we are working with you all and disseminate this information to all of you. We have a regular contact with the MOHs and the REs, and this is a golden opportunity for all of us to work together. Thank you.
Thank you, Dr. Karuna Pema. So with that, we will continue with the rest of the session. So as I mentioned, we'll be moving now to the next panel discussion. So I'll be moderating this session. And for as panelists, we have several physicians, pediatrician and consultant, gynecologist and obstetrician with us. So we have Dr. Vimalasiri Uluwathage, consultant physician from National Hospital Galle. Professor Lakmal Fonseca, consultant physician in the Department of Medicine, University of Ruhuna. And we are very happy to collaborate with the College of Gynecologists and Obstetricians. So we have Professor Madhura Jayawardena joining, who's a consultant gynecologist and obstetrician, and a senior and a professor in the Department of Gynecology and Obstetrics in the University of Sri Jayawardenepura. And we also have Dr. Jagath Ranasinghe, consultant pediatrician, representing the Sri Lanka College of Pediatricians. He's at the moment, Dr. Ranasinghe is working in Sri Bandanayaka Specialized Children's Hospital at Peradeniya. And we also have Dr. Tushani Dabrera, consultant community physician and also focal point for leptospirosis in the epidemiology unit. And Dr. Dabrera has been helping a lot in getting this organized, as well as encouraging us to talk about leptospirosis as well as other infections. So with that, we'll move on to the first scenario. So what we will be doing during this session is to go through 3 scenarios and then discuss how you as a first contact doctor should assess these patients as well as manage in the outpatient setting. So before I actually move on to the scenario, I would like to ask Dr. Uluwathage another question. So Dr. Uluwathage, who are these exposure groups that have the highest infection risk after floods? Will you be able to elaborate on that?
Yes. Can you hear me, Nilanka and
Yes.
everyone? Yeah. Actually, considering the special situation, disaster situation, and following after that, and the first thing is the people who got directly exposed to the flood, and their homes or workplace or farmlands got flooded, and most of these people got exposed directly to the flood. And also the people who got affected due to landslide, and they had prolonged and very extensive exposure to a muddy and contaminated environment and wet soil, and all these things special consideration should be pay special consideration. And then after these acute incidents where people got exposed to flood and landslide, then they were displaced. Majority of them are living in temporary shelters and overcrowded places where they have a high risk of contracting diseases due to people-to-people exposure, as well as the living conditions that they are having, poor hygiene and poor nutrition, and also the risky environment surrounding that those places where they have been displaced. And then the fourth category is the rescue workers and the people who are engaged in irrigation work, especially this construction, repair of these damaged dams and various other places, and also construction workers. These rescue workers, even though the exposure is limited, the irrigation workers and construction and rest of the other work will continue for several weeks in time. So these people will have continued exposure risk. And then once people are resettled in their usual environment, still in the homes and various places, still their surrounding environment is risky because of this presence of mud and very wet and contaminated soil, as well as the drinking water, especially the wells, kind of drinking resources would have got contaminated. So we need to pay all attention of all these things to assess the risk and think about when a patient presents to you.
Thank you, Dr. Watike. So I think that highlights the importance of taking a proper history about the exposure in these groups. And I would like to ask Professor Fonseca, Lakmal, what are the medically vulnerable groups that we should be concerned about?
Thank you so much. I feel I could categorize these people into, like, I was thinking whether we can categorize into 3 groups basically. There are, although we say medical, there are physiologically vulnerable groups such as pregnant and postpartum women, and also children and elderly people who are frail. So those are one category that we have to look at. And there are people who are having like medical conditions or comorbidities, we call it. They might be having some organ failure, chronic kidney disease, liver issues, and lung problems. And also people who are having uncontrolled diabetes, they may have lost their medication and maybe having high blood sugars at that time. People who are having cancer or immunosuppressive medication. Another group that we should not forget is, although they are not having any diseases, there are vulnerable conditions, such as there are people who may be having learning disabilities, and some people might have thrown into extreme poverty because of loss of all the infrastructure and finances. And also they may have psychological disturbances. They might have lost someone close to them, or disturbance due to loss of their their home. So they might be not in their correct state of mind, and they might not be very compliant with the information that we are going. So we have to be very empathic when we approach them. Now, also, people might be having psychiatric illnesses also. So altogether, there are physiologically vulnerable groups, medically vulnerable groups who are having comorbidities, and they might have been vulnerable due to the state itself.
Thank you, Lakmal. And before I continue, I would also like to mention that for the participants, as a rule, please keep your mics muted so that there won't be any disturbances to the session. And I would like to ask Dr. Luatake, now in this session also we're discussing a lot of scenarios and infections. So we actually, when we prepared a guide from the CCP as well, we emphasize the need for assessing any fever in these high-risk groups on day 1 itself. Could you tell us why it's very important to assess them on day 1 itself?
Yes, considering this situation, and most people are at risk in this environment are at risk, and a great majority of these people are living in displaced sheltered places, and also these places are heavily overcrowded, and because of that, even a day 1 fever is quite important, because perhaps once you detect, you might you can take precautions and take them, separate them from the rest of the crowd. Then the possibility of mass spread of these infections can be limited. And also, people in these places, people are under a lot of stresses because their illnesses are not the main priority for them, and they are under stresses and a lot of due to various reasons. And because of that, they will tend to forget about their physical illness, and perhaps they might, this condition, the feverish condition or whatever the medical condition, can progress without their knowledge or anyone else's knowledge. Moment patient or person reported a febrile illness or kind of illness, it's very important to take note of these things. And perhaps Lakmal may have some furthermore on this idea of starting treatment or paying attention for fevers in the first day itself. I think you can share, Lakmal, your thoughts.
Yeah. Thank you, Dr. Luatake. I think the best tools that we have as clinicians, in being the first contact doctors, is the history and examination. It is of paramount importance. So pay attention to that very carefully. When you see an individual who's having a febrile illness, look at their symptoms and signs, ask for the history to look at differentiating features of the infectious diseases that we see, and also do a proper examination, focusing on the differential diagnosis that you come across. Ask about the exposure history, check for comorbidities, and also look at the vulnerability of the patient, as I discussed before. I suggest to look at the infections in two ways. There are infections with a clear focus, and there are infections without a clear focus, which means does not have localizing physical signs. So, if you see a febrile illness, if the patient is having a focus or a localizing physical sign, patient might have one of these three things. Maybe patient is having a respiratory illness, maybe a cellulitis or soft tissue infection, or a urinary tract infection. Especially in people who have got caught to like landslides and having uncontrolled diabetes. Remember melioidosis because they have localizing physical signs and it might develop late. But in the initial few days, it's difficult to differentiate. You have to keep an eye on the progression. And there are instances of febrile illnesses that you don't find localizing clinical signs. You don't have any crepitations in the lungs, urinary symptoms, or redness or erythema in the skin. So in these instances, suspect dengue, leptospirosis, typhoid, and also in certain instances, chikungunya. So this is the basic framework up that I suggest as a starting note.
So with that, I think we can move on to the scenario, which we can actually apply that as well. So the first scenario that I would like to bring up is a 34-year-old man who's exposed to floods, developing fever for 3 days, and he's also having cough, pain, red eyes, headache, and vomiting. And obviously exposure is that he has cleaned these flood debris and has been involved with that. So he was exposed and a high-risk person. And his other parameters, he's tachycardic a bit, heart rate 104, blood pressure 100/70, and he's febrile. So I would like to ask Dr. Luatake, based on this presentation, so what sort of infections come to your mind? And I think we have already elaborated on that, so we can point out the infections.
Yes, as Lakmal mentioned, since there are no localizing signs for to explain the fever. So the first thing we need to think about the possibility of leptospirosis, because the clinical exposure history and the clinical features are quite telling with that possibility. Especially fever, high fever, muscle aches and pain, especially in the calf pain, and red eyes. And looks like he has been vomiting, but perhaps he must have. He is on the verge of dehydration, so he's tachycardic, and perhaps his blood pressure blood pressure is given and it's low, and perhaps maybe because of that, or it may be because of the severe sort of leptospirosis. The second thing is, second possibility is, as Lakman mentioned, the dengue is high possibility. The clinical picture would be the same. And there again, you can't clinically differentiate them quite confidently. But at the same time, chikungunya is also in the card. And I have seen people coming from, especially from these crowded places where when one person gets similar illness like chikungunya, most of the others also have shared similar symptoms and signs. Or chikungunya become a possibility given the place and the scenario. And also typhoid is a distant possibility, even though it's not a very common infection nowadays in the country, rest of the part of the world, country. But since because of this special situation, we have to think of typhoid as well. So those are the possibilities when there is no localizing signs or symptoms for any obvious cause of this patient fever.
So what
If I add something to Dr. Udwata's the comment, if a patient is having chikungunya, they will have arthritis and arthralgia at this point. So that's a good way to differentiate. And usually the vital signs can be normal in them. Just yeah.
Arthritis will be quite prominent at this
Yeah.
stage.
So those are the common infections that we see, and I think the importance is that we have to do an assessment, quick assessment as a first contact doctor, because any of these infections are possible. So what sort of basic investigation should we do at this stage?
Yes, that depends on the availability of facilities actually. And if you are working in a GP practice or primary care hospital, still you can do full blood count, and that will be useful. And in leptospirosis, you will see most of the time normal or high white cell count with high neutrophil leukocytosis. And in dengue, it's standard thing is that it will look like a viral picture. And in
We would say full blood count, and
yes.
if we were able CRP, at least as baseline investigations
Yes,
would be useful
CRP,
if there's no
yeah.
clear focus.
Yeah, CRP would be quite useful in this situation because which will help to differentiate leptospirosis and dengue, perhaps at the initial stage, because in leptospirosis you get high CRP usually. And if facilities are available, doing serum creatinine would be added value in identifying leptospirosis. Yes.
Just to add one thing, if you look at the CRP, if it is more than 40 as a rough guide, it is suggesting a bacterial sort of infection, including leptospirosis. And if it is less than 40, it is more towards a viral sort of etiology and can be a very mild sort of a bacterial infection.
Thank you, Dr. Duarte again from Swansea. So now, suppose these patients now there's no other focus, and we are thinking it's most likely leptospirosis, and actually we are concerned about it at the moment as well, because unless we identify early, of course, the mortality could be quite high as well. So what is the antibiotic that we would recommend as an outpatient for such a patient if we suspect mild leptospirosis? I would like to ask Lakman.
Yeah, so as this is the day 3 of the illness, we would be getting a feel of where the disease is progressing. And we can identify whether it is a mild illness or a progressing illness to a kind of a moderate to severe illness. So if it is mild and if you think it's not progressing, you can administer oral antibiotics. The doxycycline 100 milligrams BD is the common one that we use. But also remember, even if it is not available, amoxicillin or even penicillin is equally effective against leptospira. So as amoxicillin is sometimes very much available, you can give amoxicillin 500 milligrams 3 times per day. And the usual duration I would stick to is 5 to 7 days in these patients. And if you come across a patient who is on day 1 of the illness, I might not start on antibiotics unless there are like extremely clear-cut features, but usually day 1 fevers does not have much features. So in that case, it's important to review these patients in about 48 hours, and maybe you can see the patient at the day 2 or day 3 from the onset of the illness.
So I think the important message is on a day 1 fever, we assess them. And if we think our investigations, in such a case when it's not very clear, probably basic investigations will help us to find out whether it is a bacterial or not. So if we suspect, so important thing is not, if all the patients are not having leptospirosis, there could be many infections. But if it is leptospirosis, I think then we could commence treatment and then review as well. So who should be actually referred for admission there?
Yeah. So then we can, so as we are the first contact doctors, sometimes we might be in the field as well. So it's important to have a global clinical assessment of the patient. So, your fifth sense is important here, looking at how ill the patient is. That's the first thing that I, suggest. And the second thing is to see whether there are any organ manifestations. In leptospirosis, we see commonly acute kidney injury, evidenced by low urine output, and they might be having some instances they might get like myocarditis evidenced by chest pain, and they might have respiratory symptoms indicating pulmonary hemorrhage in the earlier setting. But with the global assessment and organ manifestation, and also add to that, if the patient is in a vulnerable sort of a group. So considering these three, I think you can identify whether the patient needs admission or not. And also, if a patient has been on therapy for a certain illness, or if you are having a diagnostic dilemma, or the patient is progressively deteriorating over a few days, then it's important to admit those patients as well.
In addition to that, I think if there are any history of substance abuse and alcohol dependence are also at a high risk, and perhaps their history is also not reliable usually. And if you don't take risk, and if you think that that category of patients are, should be admitted. Yeah.
Yes.
So we had a big discussion about mainly the adults, but I think pediatric population is also very important because they are also significantly affected, and especially when they're in shelters and also exposed to floods. So I would like to ask from Dr. Jagat Ranasinghe, now if with these symptoms, if a child presented to a first contact doctor, would the differentials change, or what do you think about the likely causes?
Thank you, Nilanka. Thank you very much. Yes, actually, in pediatrics, there are two groups here because as you see that up to 12 to 14, the 12 to 14 group is similar because there is no change with the management, what we have discussed, and the clinical presentation and science mostly similar. But in the less than 12 years is the challenge. And children's actually, if we go back to the history, the history says clearly the conjunctival suppuration and the headache, vomiting, and there is a muscle pain with the background history of contact with the muddy water. So I think first differentials, as we all know, it has to be leptospirosis until proven otherwise. But we have to keep in mind that most of the children with leptospirosis may not manifest all the physical signs. And there may be need very high suspicion, and also they might not have this red eye conjunctiva, the redness of the eyes, or maybe they do not manifest as adult the myalgia, or they just may have fever with the contact only. And also with the given context, we can't forget about the other vector-borne diseases like dengue and chikungunya, which can present in the similar way. And also that child is having the vomiting and other symptoms, so we have to think about the salmonella or the typhoid fever. And one thing not to forget, because children's physical signs may not manifest as we expected, so we have to have a very high degree of suspicion on what we are treating with. Yeah.
Thank you, Jagat. So what do you recommend as a treatment for leptospirosis in a child?
Yes, thank you. So 12 to 14, as in the adult, we can use the adult recommendation. There is no change of that. But the problem is less than 12, as I said. So I would like to categorize these children with suspected leptospirosis into two categories. The one is with the mild disease, and the second category is the who has established leptospirosis with the complication. So if they are mild disease, even on the day one, as we all discussed, we would recommend to start treatment on the grounds of suspicion without waiting for the confirmation of leptospirosis. So the drug of choice is amoxicillin. You can use 30 to 50 milligram per kg, but we expect you to read for about 7 days. Same time, if there is any possibility, like any contraindication, any allergy or something, we can use azithromycin 10 milligram per kg for 5 days. Maybe you can extend. So in the same time, as we are starting the day one treatment, we have to monitor these children in the outpatient department. And you have to do the full bed count and CRP. There is no difference in the investigation as the Dr. Uluwatage and the Dr. Lakmal mentioned. So there will be normal or high neutrophil count, low platelet, high CRP. But the CRP may be even little high or very high. So that is we have observed. And the other endocrine involvement may not see in these mild cases. But if you come across a patient who had full-blown leptospirosis, very ill children, please don't keep it in the outpatient department. You have to immediately admit to the hospital. And also the children with comorbidities, maybe they are on the other treatment for the blood transfusion dependent anemia, or maybe with a complicated renal disease or liver disease, or maybe epilepsy, or maybe other the patients who are on the follow-up. Please kindly refer them early without investigating and waiting in the fields.
Thank you,
So
Jada.
I think I would like to tell one word about the doxycycline because it is quite debatable at the moment. If you really want to start doxycycline in the absence of other medicines, then there is a provision above 8 years, but you have to consult a pediatrician or someone with experience with using the doxycycline.
Thank you, Jagan. With that, actually, so you clearly mentioned who should be admitted as well. With that, I would like to turn to Madhura, Professor Madhura Jayawardena. In pregnant mothers or mothers who have delivered, what do you think about managing these patients when they present with an infection post-floods? Should they all be admitted, or how should they be assessed?
Thank you, Lanka, for considering pregnant mothers in this forum because it's very important. As already mentioned, pregnancy is a physiologically vulnerable state for infections. And on top of that, when there is a disaster happens, there will be other circumstances which will make them more vulnerable, like psychologically disturbed, and all that needs to be considered. And postpartum pyrexia or fever during pregnancy, with or without a disaster, can become a disaster because it's one of the main contributor for even maternal deaths. So in this situation, I think we need to consider whether to admit or not to admit when a pregnant woman or an immediate postpartum mother comes with fever. We need to consider that postpartum fever very seriously, and we need to basically keep a very low threshold for admission. That's one fundamental practice that we all need to keep in our head when we are managing these women. And if you feel that we are overwhelming the healthcare system, I'll tell you very few criteria that we can consider managing those women in this situation as a outpatient. Let's say if the patient is having low grade fever and there is no obstetric issues, because we always need to consider, like when you're managing, we need to assess the severity of the infection, plus there will be obstetric issues which is directly coming from the infection itself, like preterm labor, abruption, fetal demise, all that can also happen. So we need to, when we are dealing with these women, we need to assess the obstetric aspect as well. So if you rule out obstetric issues like pain, discharges, uterine tenderness, which are telltale signs of possible infection, and if you feel in this difficult situation, if the person, the mom is reliably followed up in the next few days, and then if you find there is a clear benign source of infection like upper respiratory tract infection, which is also common, then you might consider managing these women as outpatient. But for the assessment part of a pregnant mother coming with postpartum pyrexia, we need to consider seriously the severity of infection. Now, all discuss high fever is a telltale sign of a severe infection, fever more than 38 centigrades or 100.4 Fahrenheit. Plus, then we need to consider systemic signs when they come with fever. Usually, physiologically, pregnant mothers and immediate postpartum mothers having a tachycardia, a little bit of higher respiratory rate, you might consider as normal. But if you see a woman who is having heart rate of more than 110 or respiratory rate more than 24 with low blood pressure, then you need to seriously consider as a severe systemic infection. On top of that, those women actually had a disaster in their life and they may be having psychological disturbances. But if you find there is an altered mental state, like they are not responding well, you might think, okay, this is psychological disturb, but that may be a telltale sign of severe infection. So all those things you need to consider when you are deciding on admitting. So if you find a woman who is having tachycardic, respiratory is high or low blood pressure and altered mental state with fever, consider admission. And then the obstetric status you also need to consider, like if they have vaginal discharge, abdominal pain, which are signs of apart from possible infection which is coming from flood, there are other obstetric causes like chorioamnionitis, wound infections. If you find those things, you need to consider seriously sending them for admission rather than letting them go and giving some antibiotics for assessment. So in a summary, if I to say, keep a very low threshold for admission when it comes to pregnant or immediate postpartum mothers, because they are vulnerable and they can progress quickly into severe form of sepsis. And then if they delay in seeking medication or medical attention, we might lose them because that may be a little too late to start treatment. That's what we see. And the take-home message is low threshold for admission unless you feel it's a very obvious mild form of infection.
Thank you, Madhur. So with that, I would also like to ask from Dr. Tushani Dabrera, because we discussed this infection of, many discussed leptospirosis actually. So there are a lot of patients at the moment exposed and at high risk of getting the infection. So what's the place of post-exposure prophylaxis of leptospirosis?
I'm sorry, I'm just answering Tushani's Zoom. She had to go out for a moment. She will be joining very soon. She just had to leave for 2 minutes. She will come back.
Okay, so we'll with that
So
start.
this is the monitored accounts. Contact AGM. I presented the draft version. So nothing drastic, no change, but it was unsigned. Because we actually had to
Shani, we cannot
Shall
hear
we
you.
proceed to the next question? I think
Yes.
she's.
Sorry, Nilanka. I'm in another meeting. I will go through this. Thank you very much. So the question was, who are the eligible people to receive prophylaxis?
Yes, what would you
Okay.
recommend?
Yes, actually, doxycycline prophylaxis for the past few years, from actually 2011, we have been giving for high-risk people in selected districts when there are known outbreaks, or when we know there's going to be an outbreak due to either floods or during the cultivation or harvesting period. So it was very limited to let's say 8 or 9 districts. So it was not widespread and it was not widely used. But due to this nature of this risk at the moment, with most of our country affected and the leptospirosis patients being reported from January 1st to December 31st from all over the country up to now. So we have actually seen many patients coming from the areas that were not designated as high risk. So at the moment, the updated guidelines, which were initiated with the support of the College of Physicians College of Pediatricians and others as well, and with the Leptospirosis Multidisciplinary Committee, the post-exposure prophylaxis is actually, we have updated guidelines and given under the signature of the DGHS. So there are, as Dr. Ulwata mentioned in the very early slide, the high risk groups are the people who are affected with floods. So affected means either they are within their own homes or they may be in a welfare camp and they may have been subjected to floods, but now they are secure, but they have anyway exposure to contaminated water. So these people are like the affected communities, and there are people who go to help those people like Triforces, police, the disaster response teams. They are also at risk, and we usually, even in the past, we have given the prophylaxis for them. And then there are other people who, like civil administration, like the Diarrheals, the AGA staff, and the other officers who will support the other administrative work, the relief work, and all that. So we have to consider them because they are also submerged sometimes, and we have experienced their risk as well. And there are other people who, like with the calamity that has happened, who will go out to help those people, like people from other districts and other areas. They will come to help the victims and help to clean out the debris, clear out the places. And earlier also we advocated to give them prophylaxis. Now we have put that in writing in the guideline. And then, of course, in the meantime, we, with the floods, with the affected disaster, we have people who do their routine work as well. The agriculture workers, construction workers, and the others who are working in the community, and they are also at risk. So we have to consider them as well. So most probably in the clinical setting, you may encounter people, random people who will come and say, I have got prophylaxis for leptospirosis. So highly likely because of the widespread damage that we have seen. And those are the people who are really affected, and those are the people we are advocating for prophylaxis. And as emphasized, we in the public health setting, because we give the doxycycline through the MOH, who will designate that to the PHI, and we do not advocate giving prophylaxis with doxycycline to pregnant women, lactating mothers, or children under 12. So that is a very, very strong message that we have given to our public health teams. So they will not give those drugs, but if by any chance, if there's a person who needs prophylaxis, the specialist, the clinician can, of course, or the VOG can, of course, decide on that. And this is our guideline is for the public health purposes as well as for the primary care doctors. So I hope that clarifies. Thank you very much, Nilanka.
Thank
Yes.
you, Tushan. So I think if I'm to again summarize, so we, according to the public health guideline, the circular as well, so most patients should have repeat received. And apart from that, as a first contact doctor, if you come across such a patient who you feel was exposed, as a post-exposure, then we can consider giving doxycycline 200 milligrams single dose. And that's what we have discussed, I think. And also, that is the post-exposure prophylaxis. And there was one other question about, I think there was a question about pregnant ladies and children, which Tushan, you mentioned that we are not advocating prophylaxis. And there was also a question about treating pregnant ladies with who have leptospirosis. Dr. Luatiki, will you be able to quickly let us know the antibiotic recommended for a pregnant patient with leptospirosis?
Yeah.
Dr.
Can you hear me now?
Yes.
Yeah, it's azithromycin and the drug of choice. And if it's not available, perhaps you can try amoxicillin as well.
Right, okay. But of course, as we mentioned, a pregnant lady with leptospirosis will most likely be admitted rather than managed as an outpatient. So with that, shall we move on to our second scenario? I think the main infection we were concerned about was leptospirosis. But with that, we also wanted to highlight two other scenarios very quickly. As a first contact doctor, you might find it very important on how to assess these patients as well. So the second scenario is about a 27-year-old pregnant lady, the 32nd week of pregnancy, presenting with diarrhea, vomiting, and of course, she admits to have been drinking some flood-contaminated well water. So I would like to ask from Lakmal, how would you assess such a patient in the outpatient setting?
Yeah. Thank you, Nilanka. I think it's important to assess the symptomatology of this patient. Diarrhea, vomiting, and what's the, just in the history, you can assess the, the frequency of diarrhea and vomiting, especially if they cannot, hydrate themselves. You have to expect the patient would be in a dehydrated sort of a position. And, sometimes even viral diarrheas can be highly frequent. Sometimes they might have 15 bouts of diarrhea, 15 to 20 per day, even in the early part of the illness. And also then clinical in the examination, just assess the skin turbo, the dryness, the mucosal membranes, and also assess the urine output, whether it is reducing. And you can assess the, hemodynamic stability by assessing the blood pressure, pulse rate. And also sometimes in a patient who are having hypovolemia, they might complain of dizziness. So by assessing from the overall assessment, asking from the history, the frequency, you get an idea what's the fluid loss is, and then you can assess the dehydration signs and also the hemodynamic instability.
Thank you, Lakmal. And I think others, as you mentioned, whether it's watery, as well as we might want to ask whether there's blood and mucus, any abdominal pains as well in the patient.
Yes, exactly. So if the patient is having a very high fever, abdominal pain, and diarrhea with blood, in that case, we are suspecting a dysentery or a bacterial infection. And if it is pure watery diarrhea with low-grade fever or a very mild or no abdominal pain, in that case, we are suspecting a viral etiology in these patients.
So I would like to ask Dr. Luatike now, this is a pregnant lady that our scenario is, of course, but any patient who's presenting with a diarrhea in this post-flood period, or do they require antibiotics?
Not always, and often we have to consider the red flags actually. If the patient is having, as Lakmal mentioned, if the patient is having blood and mucous diarrhea, if the patient is having fever, abdominal pain, and tenderness, and if the patients, you think that having profuse diarrhea and vomiting continued for several days and causing severe dehydration, if the patient is having sort of evidence of severe dehydration like low blood pressure and low urine output, probably you would consider. And also the in the context of how this patient got this diarrhea, like depending on if there is an outbreak of similar kind of people with similar kind of presentations, and previous diagnosis of this scenario being as bacterial infection. In that, taking into these kind of considerations, I think will decide the start indication for the antibiotics and decision. Yeah.
And Dr. Luatike, when should we admit a patient with diarrhea?
Yes.
If this patient was non-pregnant in this situation, of course, as Madhura correctly mentioned, patient might need actually admission and then assessment.
Yeah.
As well as management, but if not pregnant, when would we
Yeah,
consider
I think it's better to admit a patient who is complaining of blood and mucus diarrhea and profuse and water diarrhea, even if it is watery, if it is profuse and associated with vomiting. And also evidence of dehydration, because you can't manage these patients in the temporary shelters with significant evidence of dehydration. And also, if the patient is having low blood pressure and low urine output, especially in the children and elderly, yes, those are the indications for absolute indications for admissions.
with that, I would also like to ask again from Madhura. Madhura, like if this pregnant lady developing diarrhea, what are the maternal and fetal dangers that you anticipate?
Yeah, Nilanka, if you get a pregnant lady with nausea, vomiting is very common in their pregnancy as well. So if it is mild version, it may not cause major problems. But if it is severe enough to make the lady dehydrated, so she can get a intravascular depletion of fluids, and then she might go into electrolyte imbalances, hypokalemia, things like that, as well as they might end up in acidosis. So those things we need to correct that. So those are the maternal aspect of it. And then once they have severe infections, they might also get obstetric complications because of the infection, such as preterm labor. Uh, can happen as part of severe diarrhea and vomiting. At the same time, the same illness can cross the placenta in certain instances, and then it might affect the fetus. Fetus also can end up in hypoxia, and even fetal demise can happen, as well as maternal complications like preterm labor will put the fetus vulnerable to end up in a preterm delivery. So those are the things that might affect when it is severe enough to cause these problems. Of course, if it is mild, nothing may happen. But if the disease is severe, those are the maternal and fetal adverse outcomes that might need to be considered.
Thank you, Madhura. And Tushani, are you available if I'm to ask about notification activity?
Yes,
Because I
yes,
think
Nilanka. Just
although
give me
we
1 minute. No, sorry. I can answer now. So
So I think this could be just one patient that your first contact doctor sees. But if it's a
yes,
patient coming from a shelter, it could be the first patient of an outbreak. So
outbreak.
it
Yes,
could be very important that the epidemiology unit also get to know that there is this sort of impending outbreak. So how should this notification happen from a GP or a family
yes.
physician?
Thank you. Nilanka. Actually, as our chief epidemiologist mentioned at first instance, notification is really, really important because this is where we get our information, not just to curb any outbreaks or control the disease, but to allocate resources or any whatever the human or other resources that we have to give. So for your information, we have actually following this flood issue, anyway, we had adequate stocks of doxycycline as well as TCL, chlorine, Lysol for cleaning up properties for the normal flood. But this time there was heavy widespread flooding, so we had to quickly get help to procure our through our donors a lot of resources for disinfection and other purposes. So we showed our data. So if we don't show that, if we can't show whether we are having any dysentery, typhoid, so hepatitis in the normal run, I mean, nobody will be able to allocate funds. So we actually, our system, we have that data, and dysentery, diarrhea, hepatitis, typhoid, whatever, leptospirosis, the notifiable diseases. So it is your duty, our duty. So it could be one patient for you, but it might be the tip of the iceberg. So there may be other people in the community, and the hospital will be overcrowded if we leave it like that. So once you notify our PHI or the MOH or the other staff, they will go to the place, the address where you give, and they will inspect and try to curb the whatever the outbreak or the other epidemic or whatever. However, the notification, there will be a problem because in our system we have the H544 and the ICNO is there, and now we have the dashboard. For the GPs, we know it is difficult, but you can notify the area MOH either through phone, WhatsApp, email. You can do it, or the PHI. So please keep that in mind. Of course, we usually ask you to mail H544 if you have, because some GPs have and they notify, and some private hospitals also have the H544. Even if there is no H544, it is really welcome that we get your notification. So it could be like the diarrhea could be anything. So this is our opportunity to curb any outbreak that can be very severe, let's say hepatitis or cholera. We don't know. We have not had any cases of cholera since 90s, but we don't know what will happen. So your notification is very much important. Thank you very much.
Thank you, Dushan. So with that, I would also like to ask from Jagat, what are the warning signs in a child who presents to a first contact doctor with diarrhea, and when should the child be admitted again? And also, yeah.
Yeah, thank you, Rinaka. So, diarrhea in children can be a manifestation of a systemic disease, or maybe a diarrhea, as we all discuss, disease as a gastroenteritis. So, as the first contact doctors, you have to take history in detail, as we discussed, to see what is the etiology. But the killer in the diarrhea is the dehydration. Now, you know, these children have very small reservoirs because their weight is very low. So even sometimes few episodes of diarrhea, they can go into severe dehydration, and they very difficult to treat, feed, and they might refuse the usual whatever they are drinking. So the warning signs, if I talk, you have to look for the evidence of dehydration, as Dr. Uluwatthige and Lakmal mentioned. So similar things are applied, mainly the dry lips and dry mouth, shrunken eyes, and also maybe the child is having the reduced urine output for the last 6 hours, and they may have in advanced cases the cold line or the peripheral coldness. But in an infant, if you have to always check for the anterior fontanelle, so depressed anterior fontanelle. So those are the key signs of the dehydration. And also, please look at the child general well-being. If the child is ill, that is ill. If the child is ill, in that case, you have to refer to the immediately to the nearest hospital. And also, if there are evidence of dehydration, obviously, if you can't manage in the outpatient setting, so you have to get admitted. And also one word about not the watery diarrhea. If it is like blood and mucus diarrhea, or if the child is having profuse vomiting, if the mother is unable to feed continuously, so please refer them to the admission.
Thank you, Jagat. So with that, I would also like to ask about ORS. Like, how should the
Yes.
ORS, can you give all the advice as a GP should give a mother of a
Yes.
child who's in diarrhea about ORS?
All right. Yeah, the ORS is the commercially available ORS at the moment market is hyposmolar ORS, which is the change preparation of WHO, which can be used across all ages above 6 months. So you don't need to add the water as in the past. So you have to just prepare as the sachet mentioned. So this hyposmolar ORS you can give about 6 months without any problem. So main thing is giving the ORS, because many children will tend to refuse. So what you need to do is give a small aliquots, encourage the mothers to give small aliquots of fluids. So you can use a spoon and maybe about every 5 minutes, 10 minutes, 1 or 2 spoons. So by about 1 hour, you will be hydrating the child. If the child is having vomiting, you can prescribe domperidone if you have 0.25 milligram per kg, the usual standard dose. And in addition to the ORS, you can use other fluids as well. So there is no restriction to ORS, but ORS is the best, as we all know. But you can encourage them to have other kanji, soup, or even king coconut. If you don't have anything, you can do water. And if you are breastfeeding, please encourage breastfeed. But you do not need to introduce any other fluids. So you have to encourage or continue the breastfeeding as it is. In case if you don't have ORS available in the commercial preparations, especially in like a places where refugee camps or the like more gathering, there is a way you can prepare ORS in the field. So what you need to use 1 liter of water, cooled and boiled safe water, and you can add 6 tablespoons, that is a level scoop, 6 tablespoons, the teaspoon, sorry, not table, teaspoon, 6 teaspoons of sugar, and a half of teaspoon of salt. So with that, it will give the similar osmolarity to the ORS, so which we can use.
Thank you, Jagat. With that, and given that we have actually, I do apologize for the late start of our session because of the technical issue. But with the fact that we are stressed a little bit about the time with the given scenarios, I would also like to just ask a few questions in the the third scenario, which was supposed to be about a respiratory tract infection. And I'm sure all the GPs and all the family physicians, you're all aware about respiratory tract infections, and especially that has been asked quite a. So I was asking whether, can you tell us about the assessment, initial assessment, and the antibiotic strategy of a high-risk patient presenting with respiratory tract symptoms?
Yeah, thank you so much. So I think as I mentioned before, the history and examination is vital, as these are the best tools that we have to assess patients. And I would simply in the outpatient setting, I would go for a CURB 65 score. So as we don't have urea, we can go for CRB 65. Look at confusion, respiratory rate, blood pressure, and whether the age is more than 65, and pair that up with clinical assessment. So if I would say CRB 65 with clinical assessment, that would be the best thing that we can do in the outpatient setting. So if the CRB 65 score is around 1, I would give the patients amoxicillin or clarithromycin. So amoxicillin, usually we encourage to give in adults like a 1 gram, 3 times per day dose for pneumonias, because the commonest organism is strep pneumoniae, rather than the 500 3 times per day dose. So give a higher dose, 1 gram TDS, and also you can plus or minus, you can give clarithromycin in most of the patients that you see. But if they are having a lot of drug if they are having comorbidities and a lot of drugs, maybe you suspect interactions, in that case, you can pair amoxicillin with azithromycin if necessary. So, and if the CRB 65 score is 2, then you might have to, or if the patient is having other comorbidities such as COPD or bronchiectasis, that sort of a respiratory comorbidities, I would recommend to give co-amoxiclav in these patients, because some of these organisms produce beta-lactamases. So co-amoxiclav is better in those patients. And I would stick for a duration of 3 to 5 days, 5 days basically in these patients, as we are dealing with a low risk kind of a group. And if it is more than that, you can admit these patients with proper instructions. And if a patient is having a viral prodrome to begin with, if they have sore throat or runny nose, then you can suspect a viral sort of infection. So in that case, if the patient is not if patient is very stable, you don't have to start on antibacterials. But if the patient is deteriorating, we can always refer the patients to the hospital. And sometimes in the first assessment, it's difficult to see the trajectory of the patient. So best to give safety netting advice if the patient is getting worse, if the patient is feeling unwell. They can come to a doctor if a doctor is available, roughly after like 48 hours, in like 2 or 3 days, or if not, we can advise the patient to go to the hospital for further care.
And Jagat, would you like to address the same question in a pediatric population? Because I think when we take these respiratory infections, viral infections, as we say, are more common.
Yeah.
And even in these setting where they're having overcrowding and poor ventilation, there are many viral infections that spreads. And children, it's very common again. And so how would you advise first contact doctor to assess and then proceed and manage actually the respiratory infection?
Thank you, Lanka. As Lakma said in earlier comments, so most importantly, you have to identify the etiology, because majority of children who get these respiratory infections are in viral in origin, and at least 3 to 5 days you see that prodromal symptoms, and with that only they develop these the respiratory proper symptoms. So if you identify a viral etiology, you don't need to start antibiotic. What you need to do is give supportive management, as either that, depending on the runny nose, if they have, you have to use some antihistamines, and if the feeding has affected, you have to encourage them to have the good feeding. If fever is there, you have to give the antipyretic. So then most importantly, the children, you have to get them down and review these patients, maybe in about 2-3 days time, and then to reassess and see whether there are evidence of the secondary bacterial infections. So if that is there, you can treat with the standard antibiotics, so which we also encourage the use of the amoxicillin, 30 to 50 milligram per kg 8 hourly, but a little bit of more duration, maybe 5 to 7 days. If you are thinking of the atypical cover, so as you can add either azithromycin or clarithromycin, but the problem is clarithromycin mostly children are not tolerating, so you have to use something like azithromycin there. But if the child is from the beginning is ill-looking, if the in between the fever, once you give the paracetamol, if the fever is not responding, in between also child looks ill-looking and not feeding, and the fever is not settling, that might indicate the bacterial infection. In that case, you will have to use a better or higher antibiotics. So either if the child is orally tolerating, you can try with the investigations, but you have to refer to the hospital to IV antibiotic and further investigation. The one thing about children with asthma, I would like to same time talk about, because most of these respiratory infections precipitate the asthma symptoms. So if the child is on asthma treatment, please do not stop their usual medication. So most of these children have acute what to do in acute setting. So you have the emergency treatment plan. The parents are aware. So please activate the emergency treatment plan and the acute management of the exacerbation of asthma. If it is not responding, please kindly refer them without waiting the settlement.
Thank you, Jagat. So I think with that, I would move on to a few questions that we have got in the chat. If there are new questions, we can allow probably some questions for about 5 minutes. And there was one question. I think there's a lot of queries about leptospirosis. So I would just like to ask one. Dr. Luatige, if a patient is allergic to penicillin and doxycycline, what do you recommend as treatment?
Penicillin and what did you say?
Doxycycline, yeah.
Yeah.
And doxycycline.
Yeah, azithromycin could be a good choice. And if the patient is hospitalized setup, you can start ceftriaxone intravenous.
Okay, yeah. So assuming that we don't have cephalosporin allergy, then we get ceftriaxone in the ward. Yes, thank you. And there was also another question I would ask again from Dr. Duarte. So does bathing from lakes, tanks increase risk of leptospirosis with flooding? What do we do to prevent it?
So unless if it is got contaminated with flood water or the area is inundated with flood water, if the pools are properly maintained, and I don't think there is a risk of contaminating leptospirosis. But any other places like tanks and other natural streams during these days, there is a risk of contracting leptospirosis if you get exposed due to this flood situation.
Thank you, Dr. Dwatika. I think we have seen several patients with leptospirosis following even whitewater rafting as well. So I think there could be quite very unexpected exposures as well. And there's another question about a patient. Is there any possibility that a patient could present in the critical stage of leptospirosis, I suppose that's severe disease, without any fever in the preceding few days?
Usual thing is there is usually you get fever, but sometimes we have seen patients coming with various other complaints. Like even last week we came across a patient with chest pain because he has had initial probably a day or two fever which he has forgotten because of the chest pain, and he has developed a severe chest pain, probably secondary to severe sort of myocarditis. And also, in that situation, patient might not come up with the history of fever. And also, if the patient is having more pressing symptoms like shortness of breath and severe body aches and pains, and sort of any other problems like coughing up blood, so they might get, present like that. But still, if you carefully ask about the patient's initial symptoms, probably he might come up with fever. Usually fever is there, but very, very rarely, sometimes patient may not remember, or patient will not have fever. But still, there will be a compatible history of exposure if you are very keen on getting a proper history. Yes.
Thank you, Dr. Dwatika. So I think if there are any more questions from the audience, like participants, we can accommodate one or two questions.
Nilanka, can I say something about the diarrhea that we see? If a patient is having a watery diarrhea, it's not. We discourage the use of antibiotics. Plus, we have seen many prescriptions. You know, the ciprofloxacin is like highly used in in diarrheal illnesses. Basically, it's best not to use like where ciprofloxacin. We discourage the use of that, especially in watery diarrheas, and it's best to admit these patients, you know, if it is a profuse diarrhea or a blood and mucus diarrhea, to the hospital.
Yes, thank you, Lakman. Right. So in the absence of any more questions, I would also like to just brief about the guide that Ceylon College of Physicians prepared. And actually, we can share this document with the primary care physicians so that it gives a clear guide about these infections, and then it's mainly focused on adults about how to manage, assess, as well as the antimicrobial we recommend and be concerned about. With that, I would like to thank the organizing the Ceylon College of Physicians that we represent, as well as our colleagues from the Sri Lanka College of Pediatricians, as well as the Sri Lanka College of Gynecologists and Obstetricians, and Palitha Karnapema, the Chief Epidemiologist, as well as the team from the Epidemiology Unit for supporting and helping us and joining us as well in conducting these Zoom session.
Thank you.
So with that, I would like to then conclude the session. The recording will be available And we will circulate the recording for anyone who would like to listen and for anyone who were unable to join, as well as there was live streaming at the moment as well. So thank you and have a good day.